and Anne for hosting me here. I've had such interesting talks the whole week, and I see lots of opportunities to build bridges between my program, which is social science and global health in Amsterdam, and we work together with people from the medical faculty in the Amsterdam Health Technology Institute, which is a collaboration with this institute here. I see many opportunities for joint work in the future, but I'm going to talk first more about my own work so you get to know how I, as an anthropologist and medical anthropologist, have been doing research in the field of global health. And yes, when I presented this title to my university for the inaugural lecture for the birthday of our university, the sex had to go out because of visitors. They thought that visitors wouldn't like it. It was not because of my colleagues. So when I asked Anne, could I do it here, she said, yes, I was very happy. So just to give you an idea of where the social science and global health program has field research sites, and I know many of you here are either a graduate student or doing a major in global health, and you can get in touch with us if you're interested in doing work in one of our projects. We're very open to having students coming to do field work with us. Also field work in Amsterdam, if you think that's a cool site. So our research is generally multidisciplinary. So even though we're anthropologists, we always make an effort to work with our colleagues in other domains of global health. And this means that we necessarily do mixed methods research. We're very open to that. But we're finding out along the way how ethnography, so our core method is ethnography, I'll tell you about that, how ethnography works in this context of mixed method. You often do nested ethnography, so in the context of a bigger, maybe experiment or trial, we have a nested ethnographic research, and we're very happy with that kind of research, because one of the critiques of anthropology is that we do such small-scale studies in very specified communities, and what does it say when we found something out in this community about the rest of the world? So with better software, with new ways of analyzing big qualitative data, we can go more to scale with ethnographic work, and that's what we're trying to do. But it's also challenging, so I want to tell you a bit more of how we deal with the challenges of combining this in-depth ethnographic work with bigger scale. It's a challenge, and you have to find new ways of analysis to do that. So we're interested in dynamics in context of change. The world is changing very rapidly, and we think as anthropologists that we can understand that really well because we work closely with people in their everyday lives, and we know what's going on changing in their life. So I'll tell you a bit more about how we do studies in the context of change. And overall, what we try to do within my program in Amsterdam is translate what we're learning across different projects into new paradigms, new ways of understanding a specific domain. And that could also be, and I'll tell you more about that, sexuality, how sexuality works in relation to reproductive health and global health. So we're not only interested in new methods, but also in new paradigms, new ways of understanding the world. So I want to go backwards with you. Mike said I've done several projects. I tend to have 7-year cycles somehow. Getting into a new area, doing the work, publishing, thinking of a new thing. And my latest work is on chemical youth. And chemical youth means, and I would be really interested if some of you want to work with me on this. Chemical youth means, as an anthropologist, I'm interested in the way young people live their lives with and through chemicals. Now, we tend to be interested in substance abuse, or maybe on the campus here, alcohol use. Those kind of things get highlighted in research. But I'm also interested in beauty products and shampoo. I'm interested in the products from your hair to your toes and everything in between. And I found out that if you ask young people all over the world about what you use from your hair to your toes, you learn much more than if you start asking if you've had any ecstasy maybe or Alderel in the past week. So it's good to have a broader approach. We call this grand tours, the chemical lives of young people. And then through the grand tours, we move into more specific, focused ethnographies on specific kinds of practices. I'm overall interested in how young people work to have body projects, to change their bodies or their minds, to be more happy, more focused, or whatever. And I'll just present 2 examples from longer-term fieldwork that I did in Indonesia with a team of young people, young researchers. And what we found out through this methodology of head-to-toe grand tours. Also, sampling-wise, we work in diverse samples, and diversity for us means doing different things in your everyday life. So being a construction worker or a student, and then we have kind of snowball sampling in each of those domains, but we want diversity in terms of what you do in everyday life. So here are some of our informants, and I'm talking about sex products here. This is one of the most important products that people use. Who knows about Soma? Have I heard of it? It's a painkiller, which is also on the market in the United States. Carisoprodol is the content. We found out, to my surprise, we would have never found this if we didn't do the grand tours, that the sex worker informants use this a lot, large doses of it. They seem addicted to it, and it is addictive. You can become addicted to it. And they were using 6 to 9 of these tablets a day. It's on the black market. You can buy it at night when you need it. And our informants said they needed this to feel confident when going out to work as sex workers. They really felt that it was hard for them, especially the female sex workers, very hard for them to go out to work for clients if they didn't feel confident. This made them feel better. It does have a kind of euphoric effect and feel confident. And they have become dependent on this. The men use it more, they said, because it makes sex better. But for the women, it was more overcoming their shame. And this is a website from the US about Soma, so that's the same stuff. I just got prescribed Soma. It's a muscle relaxant. Can you snort this pill? Will it kick in faster? Thanks. This is exchanged on one of the websites here. The drug, what is it? And then you see somebody's advising on an article on it in Wikipedia. So one of the issues in this research is how does understanding of how to use chemicals move through youth networks? And what we're finding out is that there's a lot of actually, our informants in Indonesia don't get this stuff because they don't have smartphones yet that can pick up internet. So they get it by word of mouth. Another product that we found out being used a lot, and it has taught us about sexuality of young people, is this stuff, Super Magic. What do you think it is if you don't read it? What would this be, Super Magic? Super Magic Man, actually. Super Magic Man.
Condom?
Condom, yeah, you would hope it's a condom, it isn't. Might be a good name for a condom, it isn't. So you see a woman on front with breasts, so maybe it's a libido enhancing thing. Could be. This is actually wet tissues, and when we were asking men what they were using to increase their libido, we thought they would use a lot of herbal stuff, ginseng-based products, which are on the market everywhere in Indonesia. If you go to a convenience store, there will be a couple of ginseng products there, so that you can see them and hopefully buy them to enhance virility for men. But our informants, the young men, don't use those pills. They think it might be dangerous. They're worried about the effects, too strong for them. But they use this, and this, they say this is really good because it makes them last longer. And they also say that's what their girlfriends want. They think, they feel, again, it's confidence. So confidence came up as a key theme in our studies, lack of confidence, and this is a way that young men feel more confident. They didn't talk to us about it when we did the head-to-toe. Nobody told us about it till we had a transgender female to male, transgender male to female informant who said, don't you know, everybody uses this. So we started buying it, and then in focus group discussions, put it on the table. And then the boys would start laughing. And then they kind of knew, without us saying anything, that we knew, and then we could start talking about this stuff. Now, what's interesting about this is that the sachet says it's also to protect you against sexually transmitted diseases. So it's also an antiseptic. And it has some antiseptic stuff there, which of course doesn't work for HIV. Doesn't work for HIV, in case you don't, it doesn't work for HIV. So, but men think it protects. When we were probing on this, the women said they hated this stuff because it makes boys masculine and it makes them sore. So the boys and the girls don't talk to each other about this. Through this case study of supermagic men, we learned a lot about gender relations among young people. We found out that the girls were using vaginal washes, which also are, which have a herbal component to them, betel nut extract, which is also said to protect against infections. And we think, but we haven't done the quantitative work yet, that this is a major reason for not using condoms, because people think they're being protected. This is secret, so we come to sex secrets in global health. This practice is secret. People don't really talk about it, but you know, boys give it to each other and they use it in the bathroom before they go to a party. It's a secret, and because it's a secret, nobody's talking about it, and it's not for the promotion for sexual health. Ethnographic research can be helpful to find out about secrets. You wouldn't find this if you didn't do the ethnography first, but even doing the ethnography is hard to find it out. We had to first hear it from somebody who was willing to talk about it, and then we were able to find it. Another secret, another issue, we move to a next topic, which is one of my PhD students. So secrets came out in her research on teenage pregnancy in Cameroon. And she found that a lot of girls were becoming pregnant while still being a teenager. Our Ministry of Development Aid is very concerned about sexual and reproductive rights, and they want to combat the teenage pregnancy problem through contraceptives. So the idea is if we put a lot of funds into contraceptives, making them available in Africa, we'll have less of this teenage pregnancy. If it's also available for people before they're married, that's the way the policy paradigm goes. And what Erika van der Zijt, my PhD student, found out was actually girls don't want to prevent pregnancy. They don't want to prevent pregnancy. They know they can, but they don't want to. And why do you think they don't want to? That's an idea. You must be doing a lot of global health work, so you should have an idea.
It's a way to keep their partner?
A way to keep their partners. That's close. It's actually a way to catch big fish. So many of these girls have multiple partners. And once they're pregnant, they try to build a liaison with one of their partners, preferably the one with most resources. And so Erika documented, of course this is not always happening, so you should never generalize anthropology in the sense this is always what happens. But actually she documented quite a lot of stories about women who were pregnant, and we would think unwanted pregnancy. They started negotiating to see who would want to adopt the pregnancy as a father, and even and then if they weren't able to negotiate a fatherhood, that's when they would go for abortifacients. And there's a lot of methods that they think work as abortifacients. The problem is they often don't, or they create hemorrhage. So she did very hard field work. This is really difficult field work, because she found one of her informants died because of the hemorrhage. So it's a very difficult situation. But one of the key findings for her was also that the girls keep the pregnancy secret, big dresses, while they're still negotiating fatherhood. So there's a secrecy there around the pregnancy. And then if they want an abortion, they go through local abortion, women who do abortion, and that's not a very good place to be. This is another secret abortifacient in Manila. What do you think you see here? Pampa regla, what would that mean?
Regla is period.
Yeah.
Pampa.
It's a Filipino product. Pampa in the Philippines, pampa just means four, so 4 period. So in the Philippines, church is completely against contraception and abortion. And the method that's available here on a little store in front of a Catholic church in the middle of Manila, so the store is really virtually in front of the church, sells pamparegla, herbal mixtures, which is to induce a menstruation. But left of that herbal stuff, so you can use it 1 to 2 months delay, says the details. But left of that are pills, red, blue capsules. Well, who knows what these pills are? Red, blue capsules, there's no name on it. This is Cytotec. It's a prostaglandin, which is on the market in the Philippines for ulcers. But you can use it. It's actually used also in abortion pills. So these herbalists sell prostaglandins for women who want to induce an abortion. And this, again, is important to know because it's a practice of fertility regulation in a place where a secret practice of fertility regulation. When you buy this stuff, you get a little telephone number of a doctor that you can call if it doesn't go well. So there's a kind of informal network of support. All right, so this is work that I was doing on sexual reproductive health and contraception. I want to move now kind of a little bit backward in time, a large project that I've been doing on HIV/AIDS, where secrecy also came out as a key topic that we wanted to be analyzing across several projects. So the way that I work with my PhD students is they're each doing their own topic, but we also look for cross-cutting concerns that we want to be working on together, and then we agreed to do some joint analysis of this cross-cutting area. And secrecy became one of our cross-cutting issues, and we had workshops around secrecy where people working on different projects would present to each other, and it, I'll show you later, it led to a special issue on secrecy. So one of the other, Erika was on that team, the secrecy team, who was doing the pregnancy outcomes. Another of my students, Margaret Kiakua, worked on secrecy in relation to something very different. This is preparing a cream, mobile cream, in an AIDS care clinic in Uganda. Nurses were preparing this cream, and they decided to start preparing a cream when they themselves were HIV positive and were using antiretroviral medicines and suffering from itches. The secrecy angle here is that they didn't want to have those itching and bad skin, which is related to nevirapine, because then their patients could see that they themselves were also HIV positive. And even though the whole program is directed towards being open about your HIV status, there's a lot of emphasis on that in AIDS care programs, these nurses didn't want to be open about their HIV status. They felt that it would degrade their position in the hierarchy in the clinic. So they started working with a local traditional healers to develop a cream, which their patients had told them worked for this itching. And they prepare together on a monthly basis this mobile cream, and they give it to everybody in the clinic, and they use it themselves as well. So here the secrecy led to the development of a cream that they added to the AIDS care program. Now the doctors in the AIDS care program don't want a herbal cream at all. They're concerned about the interactions with antiretroviral medicines. So actually it's an act of resistance that they're doing, but in their local rural clinic, that's what they did. So they team up now with patients and healers to develop a cream to deal with their own bodily expression of HIV. So these were other case studies in this culture, health and sexuality special issue, which we labeled secrecy as embodied practice. So sometimes you can know about a secret through the pregnancy that's growing or through the itching on the skin. Secrecy is not always something that you can keep secret. So in health, sometimes you can't keep something secret because it's growing, the pregnancy or the skin trouble. And there were other case studies there, but I don't have time to discuss that. So within this whole area of AIDS, I want to discuss one more case study, which is about work we did on preventing mother-to-child transmission And this was a multi-sited study where we were looking at people's willingness to be tested for HIV and what happens after you are tested. And in this program, one of the key issues was the lack of disclosure of HIV status. Now, anybody working on HIV knows that that's an issue. People don't always want to disclose their HIV status. We looked specifically at the Preventing Mother-to-Child Transmission program. Does everybody know how that works? So you get an HIV test while you're in antenatal care. If you're positive, you go on treatment, and also the child needs to have some treatment to prevent the child from being infected. And what we found was that the issue with this program in terms of HIV testing is, what do you think in terms of gender dynamics is the issue here? So women go to antenatal care for testing for their pregnancy, but they're tested at the same time. It means that women find out they're HIV positive sooner than their partners. So they can be seen to be the one to bring HIV into the family. And this is a concern to them. So through our mixed method research in this testing project, we found out that this is a serious concern for them. I'll show you some of that. So even though there is a confidentiality policy in the clinics, this is what I want to show you. Overall, if you look at the PMTCT statistics there, women were very happy with the testing in the PMTCT. So there was some concern when PMTCT programs were underway and HIV testing was going to be routine. There was human rights concern. Well, people have to have a choice to be tested. And actually, we found that overall, women were very happy that they were being tested. But if you look at the first column there, PMTCT, only half of them told their partners that they had tested. Told their partners that if they tested positive, only half of them told their partners. And this is a major problem. The programs were really pushing them to do so, of course, for good reasons, and they were not doing so. And we found that this is the 408 women were in our subsample. There were 63 positives. Half of them had no formal education. And the health workers said they didn't really want to talk too much about the testing because they were afraid that they would lose women and have to follow up on that. So it was kind of a situation of mandatory testing. Everybody was being tested. Overall, the women felt that it had been good that they were tested. Overall, people had had good advice. The HIV positives got better advice than the HIV negative, which makes sense. They had more post-test counseling. And then when we started probing with the 63 women who were positive, we found that 80%, so 4 out of 5 women said they would rather keep it secret. They would rather not tell anybody, and only half of them told their partners. And we found through the qualitative, so here's why mixed method is important, that if they did tell their partners, in 50% of the cases, bad things happened. So they were abandoned, they were chased out of the house. So not strange that they didn't tell their partners. And we were interested in whether this is related to self-stigma or to the fear of enacted stigma. And we found that actually levels of self-stigma, this is all in East Africa, were not very high. So people generally accepted that they could be HIV positive, and they didn't really blame themselves that much for it, but they were very worried of this enacted stigma. They were worried that their partners would, or the families of their partner would make their lives much harder, and they often did. So we were left with a real issue here in terms of recommendations. What do you recommend in a situation like this, when you know that there really can be bad things happening to women? Should they tell their partners about their HIV status? And what we ended up doing is discussing with different programs. This was in Malawi, Burkina Faso, Uganda, and Kenya, that disclosure is a process. You can't just say you're HIV positive and go and tell your husband. There has to be a careful management of the process. Now these women who test positive, they end up often being advised to go to support groups. And what we also found in our qualitative research is that when they go to support groups, they are initially less likely to disclose. Actually, these support groups are promoting openness about HIV, but at the same time, they're very pragmatic. So people talk to each other and say, well, maybe wait with disclosing, not yet. So support groups see disclosure as a process. And we found a statistical association. So from our ethnography, we went back to the bigger data set, and we found a statistical association between going to a support group and not disclosing. So support groups turned out to be one of the important predictors of not disclosing. This is an example where you see that this kind of back and forwarding of the research. So first we have the HIV data set. In that data set, we have a subset of women going to PMTCT. We talk more to them. We find out that why they don't disclose, and that support groups are important for them through just listening to them. And then we go back to the data set and find that the women who are part of a support group disclose less. So we're interested in that kind of dynamics of mixed methods. So it's not a one-way process where the ethnography is formative research to develop an intervention and then you do a trial. But even in the trial, we promote doing nested ethnography. So in the trial, you do ethnographic research to find out why things are the way they are, and then you can do more analysis to see if that's a more general conclusion. So here you see the data on the felt stigma and the fear for enacted stigma. So it's quite remarkable that in a situation where the epidemic has been going on for quite some time in sub-Saharan Africa, the felt stigma has become much less, and it's more to do with the fear for enacted stigma. So people are worried about what will happen when they're positive. So what we concluded in this research is that actually there's a high acceptance of testing in antenatal care. This was a controversial issue at the time, but it's highly acceptable. HIV positives got better care than the HIV negatives, which you couldn't be happy about. That there is mandatory testing, but so that means people don't really get a choice. So it's just a routine of testing every woman. But women were not concerned about that, but they are afraid of the enacted stigma. And they're not concerned about the mandatory testing because they want to be tested to protect their children. It's just very common. And only 50% under. So how to confront that? One of the other, so we made this point about disclosure being a process, but one of the other conclusions that we drew out of the bigger project on HIV testing is that we are really very much in favor of home-based testing. Our other sub-study on home-based testing showed that if you can go house to house in high prevalence communities to test people on HIV, everybody would think, oh my God, privacy, confidentiality, etc. But actually, if you do that properly, at least at the community level, you get a discussion going about the possibility of being HIV. So it's an opportunity to talk about HIV without necessarily pointing who's HIV or not, but it becomes something that you share. We as a community have people who are HIV positive, and it doesn't single out women as the ones who bring HIV into the community. So this was kind of, we didn't expect this is what we were going to advise at the beginning of the study, but it was important. We worked closely with World Health Organization also on their guidelines for home-based testing based on this. So this is the support groups. Members disclose less. There's a Before we go into, I want to give you time to ask questions about any of these studies. But I wanted to give you one more example of where we've been working on secrecy and this is in a nested ethnography and qualitative research in a large-scale trial of microbicides, the microbicide development program. My colleague Robert Poole was part of that multi-sited testing of microbicides. Alas, the microbicide that they tested didn't work well enough, so it's not on the market. But in the process, we learned a lot. Does everybody know what microbicides are? Who doesn't? So microbicides are kinds of gels that you could use vaginally to protect against infection. HIV, and they work in different ways. I won't go into their working mechanisms. But one of the key aspects of the idea of microbicides is that researchers thought that it would be very useful for women to use secretly. So men don't want to use condoms. Maybe they use tissues, but they don't want to use condoms. And the idea was you need female-controlled prevention methods, and microbicides could be one of them. And the design of the trial was such that the idea was that women would use it secretly, and because of ethical reasons, men would be pushed to use, condom use is promoted among men, and women would use these microbicides. And the trial designers didn't think that women and men would talk about the microbicides. What Robert Poole and his colleagues found was that men quite soon found out that women were using gels, that was something different, and that they did talk about it, and that actually a lot of the men, this is again studies in Eastern and Southern Africa, a lot of the men were happy with the gels, and that actually it was seen to be a libido enhancing product. So this maybe goes back to where I started, where you saw that those tissues are also seen to be libido enhancing and also antibacterial. So in practice, the ethnographic angle of the trial found that these things, microbicides, were valued because they were seen to do both, to protect against HIV infection and enhance sexual pleasure. But alas, the microbicides didn't work well enough, and they were taken off the market. And actually there was community demand to keep them on the market, and the researchers didn't know what to offer because anything that's there doesn't work well enough yet. I was on the steering committee, and I said, well, I think you should offer something and then at least educate that it doesn't protect against HIV, but why not say that there's other gels around that you can use? That wasn't taken up. This study has a complex mixed method, but what was done here was that you can imagine if you're trying to find out how people are using this gel, it's quite hard. How to get validated for using this stuff. So the designers, the quantitative designers said we will do coital diaries. We asked people to come back with the applicators to count how many have been used. And they did a kind of quantitative interview in the clinic to triangulate whether people are using them or not. But there were discrepancies between these three measures. And so what Robert said is, well, if there's a discrepancy between what we get back, let's talk to people. And let's just ask them, hey, we heard 3 different things from you, so what's going on? And he found out that people were very willing to talk with the researcher, the ethnographer, about what's going on. They said, that was a really stupid question. They framed the question about, did you have sex? And they said, you shouldn't ask, did you have sex? You should ask, how many rounds of sex did you have? Or people were using it in other ways. For anal sex, they were using it for hair, for hair gel, because it seems to work good as hair gel. So there was always an explanation why it didn't add up. So he said, and he published that in Soma, that it's important to actually simply ask people if it doesn't add up and get the qualitative stuff as a better, to get a better validity of your data. And also the use of the microbicides for anal sex had not been part of the trial. And we think actually that's one of the reasons why, because it wasn't measured, that the trial results were negative. And now there's whole groups of men, demanding that trials be done on microbicides for their sexual practices. So doing ethnographic research in the context of a trial, trying out something new, you can learn a lot about the way people are using it. So I said we do these studies across, we do also thinking across our different projects to come up with new ways of thinking about some of these issues. So what we realized about HIV disclosure is that HIV disclosure is never a one-off thing, it's a process. Also, it's relational. You have to think about the relations in which people disclose. Overall, it's always selective. And disclosure can also be non-verbally, through indirect speech, through just letting your medicines lie in the house. So we found people who are not talking indirect disclosure just by having the stuff around, or by seeing that people is becoming fatter again after being on ART. That's enough. You know, this person looks better, must have had ART. And in terms of sexual and reproductive health, when we did this work on contraception and pregnancy, we realized that also there we have to look processually at sexual and reproductive health. And in terms of, for example, those girls who are navigating, it's not about just an unwanted pregnancy as an event that you're trying to explain. Something happens next. So there's a whole navigation of life. Concepts that we use in anthropology are navigation and social becoming, rather than an event or an identity or something that's fixed. This means that you have to do longitudinal research. I mentioned in the beginning, we want to study dynamics. So if we can't really figure out what this event is, whether it's an unwanted pregnancy or a wanted one, you have to follow the whole trajectory through of deciding that it is going to be a wanted one or an unwanted one. Okay, that's all I wanted to say. Sex and secrecy. We have 20 minutes left for